diagnose all people as early as possible, right? So you have to testing. Then once you diagnose them, whether they have HIV or not, you could have an option of PrEP. And if they are positive, you put them on treatment. So I want everybody to remember undetectable equals untransmittable. What does that mean? So having an HIV diagnosis is not a death sentence, okay? The minute that you're on treatment, that's prevention. So this is something I definitely want to drive home in our community because there's a lot of stigma. What do we say? We always say the person has SIDA, right? That's AIDS. No, they do not have AIDS. They have HIV. There is a difference. HIV is a virus. You take your medication and you control HIV, and it never becomes AIDS. So this is something, how do you say HIV in Creole or French? VAH. Katash on l'autre gens, but comme ça. VAH is HIV. VIH. There we go. And what else are we going to do? Prevention. The newest you prevent new HIV prevention by using proven interventions, including PrEP, and also syringe service programs, right? So let's talk about this for a moment, right? So people who are sharing needles to inject drugs, they're at risk. But let's talk about something else that might be happening in our communities, right? We're having multi-generational households now. And let's say if someone has diabetes, they might be sharing syringes for insulin. So it's not just thinking about using drugs, because if you're sharing syringes for the Lantus, maybe mom and dad or brother and sister on the same Lantus, that's a way of transmitting too. So what are we going to do? We're going to respond quickly to potential HIV outbreaks to get the vital prevention and treatment services to people who need them. So this is how we're going to get to that goal by 2030. Next slide, please. Okay, so this is a chart from the CDC, and out of about 1.2 million people are eligible for PrEP, and out of that 1.2 million, only 25% of those people are actually on PrEP. And when we talk about the Black community, only 9%, and the Hispanic community, 16%, but the white community, 66%. So what does that mean? The communities that are having disparities, such as the Black and Latino, they don't know about PrEP. They don't understand PrEP. There's stigma with PrEP. But our white counterpart community, MSMs, they're taking their PrEP, 66%. So it's working. So we need to change this 9% to 16% by like what we're doing right now, education. So each of you guys are learning so you can go and tell other people. Next slide, please. So who are PrEP providers? So primary care providers, please, we don't need to refer PrEP to the infectious disease doctor, right, Dr. Dufresne? The primary care doctor can take care of the PrEP. It's very simple. It's only 2 agents. As long as the patient's renal function is within normal limit, you can start the patient on PrEP. When it comes to the 3 options, Truvada, you have to have a renal function at least greater than 60. And then for the Descovy option, greater than 30, okay? And then the newest agent called Aperture, which is an injection, which we'll talk about in detail, there's no renal contraindication. So who are PrEP providers? Primary care providers, sexually transmitted disease clinic providers, of course, HIV care providers, and also drug treatment providers. Next slide, please. So these are the indications for PrEP. So this is a nice algorithm for providers to look at. It shows you that if someone the question would be if someone is having sex with a man, woman, or both. And then the indication would be, is their partner positive? If yes, prescribe PrEP. But notice that, if the answer is no, you still discuss PrEP anyways. And if they ask you for it, you still give it to them, okay? So if you have 1 or more sex partners of unknown HIV status, and you always use a condom, yes, you still can prescribe PrEP. So the whole idea is, if anybody who's sexually active, you have to offer them PrEP, okay? So that's the whole point. And remember, let's not forget about our injection drug users. This is another possible way of getting HIV transmission. So PrEP is indicated for that group as well. So these are just some nice algorithms that the new guidelines have to help, guide the providers and knowing, who would be a good candidate. But at the end of the day, if someone tells you that they've never had sex before and they ask you for PrEP, just give it to them. That's where we're at right now. They may not want to share all the details with you. Next slide. Thank you. Okay, so let's talk about the agents. We have oral agents. So you take one tablet once a day, and then you get your laboratory test done every 3 months. And then we have our new injectable, and it's an every 2-month injectable. Has anybody ever heard of on-demand PrEP? On-demand PrEP, yeah. So there was a study done in France. It was called the Aperture study. And what they did was they did a study with men who had sex with men. And what happened is that this would only be for people who planned sex. So what they would do is they would take 2 tablets 2 to 24 hours prior to having sex. Then they would take 1 tablet for 2 more days. So that's a way that you can take the PrEP to prevent HIV. But guess what? It's not FDA approved in the US. Other countries have approved it, but our guidelines actually talk about it. Because when I started in this work like 4 years ago, my patients were going to Thailand and getting this, and they were doing it on demand. So I was learning from them. So since the CDC knows that there's people that are taking it like that anyways, they give guidance on it, but they're not approving it. Why? There's some limitations. You have to actually plan sex. And most of the time, if they're going out and partying and things are happening, there's no planning. So you would have to have sex at least 1 time a week for it to work. And you would have to only use the agent called Truvada, and it's only done in men, right? So now women cannot say that they want to do on-demand PrEP, unfortunately. So next slide, please. So let's talk about the time to protection. So before we talk about the time to protection, so we have 3 agents. We have Truvada, and Truvada is indicated for everybody, for men and women, right? So when it comes to time to protection, it takes about 7 days for a rectal exposure for it to be protected. So when it comes to the men, it takes 7 days of being on oral PrEP for you to be protected. But when it comes to women, it takes about 20 days. Can anybody guess why? I'm going to pick on the nurses because pharmacokinetics or pharmacology? Why would it take 20 days for women? Because it takes longer for vaginal concentration to reach the effectiveness. So it takes longer. So that means that it's less forgiving, right? Where a guy can take it 4 times a week and still be 86% protected, if we miss it 1 time, we're already down to 85. It's definitely very important. So when it comes to Descovy, so Truvada came on the market in 2012. So now, 2019, we have a new agent called Descovy. So with Descovy, this medication is only indicated for men who have sex with men and transgender women, but not women. The only reason is because the studies were not done in women. That's the only reason. They wanted to get it approved fast, and then they didn't want to wait for women to join the studies. So there's some ongoing studies right now. Who's to say? I think it will work, but the problem is there's no studies done in women. So that's why Descovy is only indicated for men who have sex with men and transgender women. Okay, so basically, if you have a vagina, if you ever had a vagina, no Descovy for you. So basically, it takes about 7 days again for Truvada, and then 20 days for Truvada for women. So there's no studies done when it comes to the Descovy and the cabotegravir. They were not sure how long it takes for it to be protected. But the cabotegravir is also indicated for both men and women, which is the injection every 2 months. Next slide, please. So let's talk about the options. So we talked about this briefly. So the first option there, that's the Truvada. You take 1 tablet a day, and that's the one that's indicated for everybody. So remember, you're gonna have to have a creatinine clearance greater than 60 for that one. And then when it comes to the Descovy, which is the second one, FTC-TAF, it's not for person at risk of acquiring HIV from receptive vaginal sex. So that one is only indicated for men, and men who have sex with men, and transgender women. Okay, so, and did someone say something? So cabotegravir is an every 2-month injection, and again, you have to have a weight of greater than 35 kilograms to be eligible for these agents. So notice that there's no age limit when it comes to PrEP. So what do you have to do to be eligible for PrEP? So you have to have a documented HIV negative test result before prescribing PrEP, no signs and symptoms of acute HIV, and no medications that are contraindicated, and a hepatitis B status known. So basically, if the patient has hepatitis B, you do not want to start them on Truvada or Descovy right away until the doctor clears them. Why? Because that actually has a suppressing effect to prevent the flare-up. So the patient needs to know that if they discontinue it, there's a risk of the hepatitis B flaring up. Or if, like, for example, like the agents Descovy and Truvada also help suppress hepatitis B. So if they ever stopped it and wanted to go to the injection, they may need to put them on another agent, or just understand that risk. So it's important. So like I practice, I'm prescribing in a wellness clinic. Basically, my organization takes care of all the STDs for Broward County. So we work on behalf of the DOH, our providers. So if a patient came in and they had hepatitis B, we would discontinue the PrEP because we're not giving them primary care service. We're just treating the STI and giving them PrEP. So the patient would go and get treated, get a letter from the doctor, come back, and then we put them back on PrEP. Next slide, please. So again, PrEP is indicated for all sexually active adults and adolescents. They should be informed about PrEP. So a lot of times, about 1 out of 3 providers are actually not comfortable with prescribing PrEP. I'm not sure if it's because, maybe Dr. DeFrandy can tell us a little bit. Is it because they're not comfortable with it, or they use their personal moral values? You do prescribe it? But a lot of providers are not comfortable, because I've had patients come to me and tell me, like, I met this girl and she was explaining to me that she wanted to start PrEP and that she went to her primary care doctor to talk about it, and she felt that he was judging her. So she said that because her best friend actually got an STD from her partner, they decided that they were going to do it together. And she, she was well informed, and she just decided, listen, doc, I'm just going to take my PrEP, because she was well informed. So unfortunately, that's the case, that we need to, remove the stigma, and just everybody get tested, right? We're going to do a status neutral model. Everybody get tested. If you are positive, you get on treatment. That's prevention. If you are negative and you had a close scare, you get on PrEP. So if you remove that, that definitely helps with the stigma. And to talk about the stigma in our community, does anybody remember watching that movie, How Stella Got Her Groove Back? Do you remember that scene where she goes, oh, they were in Jamaica, and she goes, oh, don't they have a lot of HIV there? And then she goes, that's Haiti. You guys remember that scene? That's what you call stigma. And we definitely need to do what we can to help eliminate that. Because if someone has a diagnosis, they need community. They need somebody that they can go and talk to. So that stigma definitely needs to be removed, because again, undetectable is untransmittable. So if you have a partner and your partner is on medication, you will not get HIV as long as they stay on treatment. You can take PrEP as just another layer of protection. Let's say they decide to not take their meds one day, but undetectable is untransmittable. So we want to drive home that message. Next slide, please. My slide's not going. Okay, so this is just another slide that talks about the updates. So when it comes to PrEP, the guidelines have actually now changed. So if a person is PrEP naive, in order to start PrEP, they want a fourth generation antibody antigen test. But then when you go and do the follow-up in 3 months, they also want you to do a viral load. So a viral load is now indicated for PrEP follow-ups. And it's a very expensive test, but there's a reason why that they changed the guidelines to add this expensive test, and we'll talk about it shortly. But if the person has been on PrEP and their PrEP experience and then they want to start a new agent, they would have to do the fourth generation and the viral load in the beginning. Next slide, please. So let's talk about why. So the reason why they're requiring a viral load, when it came to the study that they did for the injectable PrEP, they found that having an antiretroviral agent, it actually suppressed the replication of the virus. So that means that someone could be positive and the test comes out negative. Why? Because there's not enough of the virus to detect it. So the viral load would probably is the test that detects it the earliest, right? So about 10 days after exposure, and sometimes in some cases even earlier. So that's why the recommendation is now to do a viral load. Okay, next slide, please. And so this is talking about the injection, the medication called cabotegravir. It's showing you that at baseline, they were able to find 3 infections with the viral load of the people in the study, and when it came to the testing, and it was actually delayed 62 days. So what that's saying is that, let's say if the person was not on a prevention medication, if they didn't have exposure to the medication called antiretroviral, it would have detected it 62 days earlier. So it delays it by like 2 months. So it's very important to know. Next slide, please. Yeah, and this is just a chart showing you. So as you can see here, the person gets infected around 10 days or so. You can get a detection of a viral load that would indicate the person's positive. And about 14 days or so, you would get the antibody. So this is how it is in the presence of no medication, such as Aperture, Descovy, Truvada, which is known as the antiretroviral, but in the presence of the medication, you see how much it delays so it makes a difference. So that's why we have to use this new expensive test that insurance are giving us trouble uncovering. So there's a reason. Next slide, please. So this is a really nice chart that just explains everything. So it just tells you that PrEP is indicated for all sexually active adults and adolescents or a person who injects drugs. So it tells you the indications. And what I want you guys to notice is that, again, you have to do the 4th generation antigen antibody if they're starting and they're naive to antiretroviral. But if they have antiretroviral before, you have to do the RNA and the 4th generation. And something to note, you need to do this every 3 months. You do their testing, okay? And every 3 months, you're gonna do your HIV antibody RNA, as well as your, at baseline, you wanna do the hepatitis B, hepatitis C to make sure, and then do that every year. So when it comes to the Descovy medication, there have been some indication of it increasing the lipid panel. So you want to do a cholesterol and also the triglyceride once a year also to just make sure the patient's okay. And there's actually been some changes when it comes to the renal testing. So when it comes to the renal testing, we used to do it every 6 months, but now they're saying to do it every year for everybody. But if the patient is greater than 50, has a renal function of less than 90, then you do it every 6 months. And there's also been some changes when it comes to the STI, sexually transmitted infection. We don't say STD anymore, we say STI. And with the STIs, you do, when it comes to men who have sex with men, transgender women, you do the testing, 3-site testing, right? and you do that every 3 months. But when it comes to the heterosexual community, they're saying every 6 months when it comes to syphilis and gonorrhea, but chlamydia every year. I'm not sure why they made it so detailed, but that's the new changes in the guidelines. So I guess they're saying there's higher incidences of STIs in the MSM community, so they want them to test more often. Next slide, please. Thank you so much. You've been so helpful. So this is a nice chart that just explains everything. So it just shows you that you do your FortGen, your viral load, you make sure you do your renal function at baseline, you do your STD testing at baseline, your Hep B and your Hep C every 3 months. For the MSM transgender community, you're doing your STIs, and then every 6 months for the heterosexual with chlamydia every year. And for your renal function, if you are greater than 50 and have a renal function of less than 90, then you do your renal function every 6 months. Everybody else, every 12 months. Okay, next slide. And this is just like a nice chart that just explains everything again. And again, they're also recommending to give the patients a 90-day supply. So if a patient's first starting, I wouldn't recommend to give a 90-day supply because anything can happen. They can have like an allergic reaction. You'll give them 30. But at their follow-up, just give them 90. It's better to help with adherence. Next slide, please. So let's talk about the newest agent called cabotegravir, brand name Aperture. What is cabotegravir? It's an integrase strand inhibitor, and it's for at-risk adults and adolescents weighing at least 35 kilograms to reduce the risk of sexually acquired HIV. So again, with this medication, you do your 4th generation and your viral load as well. Next slide, please. And so this is the study. It's called HPTN-083. So it was a study of about 4,570 cisgender men and transgender women who have sex with men. And they found that it was superior by 69% compared to the oral PrEP. Can anybody guess why the adherence is better for the injectable than the oral? Yes, no adherence issues, right. And then when it came to the study for women, it was actually 90% more effective due to the same reason. So remember how we were talking about for a woman, the Truvada is less forgiving? So the superiority was going to be far exceed compared to the one for men. So it's 90% more effective. So next slide, please. So who are the best candidates for the Aperture? So it's going to be people with problem taking oral, because the oral option, if you're not taking it and you're forgetting to take it, it's not going to work. So I do some community events, and I was talking to patients in the community, and a rumor that's in the community is that, oh, if you take PrEP, it's going to make it easier for you to contract HIV. No, it's because you're not adherent to it, and during those non-adherent times, you happen to contract it. So adherence is important. So this is a good option, but you actually have to make it to your doctor's appointment for it to be effective every 2 months, right? You got to show up. It's a gluteal injection. It's a dorsogluteal injection, and basically it's in your booty, and you get it every 2 months. So in my clinic, we actually did our second one today, and I got to watch. It was really cool. So problems taking oral PrEP as prescribed. So I went into a pharmacy. I didn't think it was going to have to be invasive, but now we're doing like all kinds of shots, and I'm probably going to end up doing Aperture shots. So I should have just became a nurse or something. So these are for people who prefer getting a shot every 2 months instead of daily PrEP, and it's for people who have serious kidney disease that prevent them from using the oral medication. So next slide, please. So what are the pros and what are the cons? So the pro is that it's a long-acting injection that lasts in your system for 2 months. And it's okay with renal insufficiency. Like if you have low renal function, it doesn't affect your kidneys. What are the cons? So you have to do more frequent testing. So that's going to be costly, right? That RNA test every 2 months It's going to be costly. And you have to actually go to the doctor's office and get the injection. And the main con is at discontinuation, there's residual concentration that remain in the systemic circulation for up to 12 months or longer. This may lead to the emergence of drug-resistant virus. So what does that mean? So basically, if you decide that I don't want to take this no more after 6 months, you know, it stays in your system for a year. And if you get exposed, because the concentration is lowering, you're at risk for resistance. So how do you discontinue Aperture? That means going on the oral for a year. So you gotta really pick your patient wisely. Like today, we had a patient who got Aperture, the first shot. He was sad because he was our second one and not our first one. But guess what? He's a prostitute. So this is a perfect candidate. So he just comes and gets his little Aperture every 2 months, and he doesn't even have to worry about bringing his pills. He said that when his partners take him on trips, he doesn't have to worry about the pills. So this is a perfect candidate. So this is not for everybody, but there are people that it's going to be good for. Next slide, please. So how do you initiate Aperture? So with the Aperture, there is an oral lead-in dose that you take for 28 days. So you take the cabotegravir, which is the active ingredient, orally for 28 days, and it's optional. So in the studies, they did the oral lead-in to test for hypersensitivity. Because if you're going to give somebody that's long-acting an injection that stays around for 2 months and they have an allergic reaction, that could present an issue. So you take the oral for about 28 days. So after the 28 days, you can come in on the 28th day or 3 days after to get your first month injection. So initiation actually takes 2 months. So let's say I took my oral cabotegravir for 28 days in April. So on the 28th day or 3 days after, within 3 days, I come back in May and get my first injection. Let's say I get it on the 1st. So the 1st of May, I get my first injection. June 1st, I get my second injection. Now that's initiation. Initiation is done. So now you start getting it every 2 months, right? So now in August, on the 1st, I get my shot. So the 1st is going to now be my target date. So whenever a patient gets the medication, whatever day is day 1 is their target date. Let's choose a different target date because 1 is kind of hard. So we'll do day 15. So day 15 is your target date. So let's say that you can't come on the 15th. You have the week before and the week after the 15th. So it's best to get it on the 15th. But let's say 1 month I got it on the 12th. But you always got to go back to that target date so you can schedule the patient because it's either a week before or a week after. It's a little complicated. Imagine like workflows for clinics, right? It's complicated. We're still trying to figure out ours right now. And then you just continue. So you do oral month 1, month 2, month 4, month 6, month 8, and you just continue. And again, you do your 4th gen and your RNA. But notice with this option, there's no need to do hepatitis B, hepatitis C, or renal. But in a public health space, I think it's still important to do your baseline. Still do your renal at least once a year, your hepatitis B, hepatitis C. Next slide, please. So again, this is just explaining what I just explained. This is a nice picture. So if your target date is the 15th, you have 7 days before and 7 days after to get that injection. Next slide. So this is just explaining, how it works for cabotegravir. So what are the differences with cabotegravir? With cabotegravir, when it comes to men who have sex with men, when it comes to the STI testing, you do that now every 4 months. And then everybody else every 6 months. So like it says you would do your initial dose, which is the oral. But remember, the oral lead-in is optional. In our practice, we're not giving the patients the oral. We're just direct to inject. We're skipping that. Why? Because in the studies, there was no issues. So then when it got FDA approved, they made it an optional. Next slide, please. And this is just that nice little chart to keep it organized again. So when it comes to Aperture or cabotegravir, all you have to do is your 4th generation, your RNA, and just the STD testing every 4 months for men who have sex with men and transgender women, and for everybody else, every 6 months. But with chlamydia, every year. Next slide, please. So again, this is just another slide to just bring home the point. Let's see if there's anything else. Provider cabotegravir injection at initiation visit, and again, 1 month later. So what's happening in a lot of clinics that they're just going from the first injection to every 2 months. Remember, initiation is 2 months back to back. So that's a mistake that's happening in a lot of places. Next slide, please. So let's talk about doses. So, our patients, like at least my patients in my clinic, they're traveling, they're living their best life, they're everywhere. So let's say that a patient missed greater than a month since their last injection. What do? You have to do the initiation doses again. And let's say that I got my Aperture injection in August, but I'm going to be out of town for the next few months. So in order for me to cover the October, right? October, I can actually go on oral for 2 months. And then when I come back in October, get my injection, right? So they actually approved for 2 months of the oral tablet from the company, but you only can get up to 60 days. But remember, there's always Truvada and Descovy. You can always go back to that. And on the last day, you take your pill, you get your injection, which is fine. Next slide. So let's talk about the safety information when it comes to Aperture. So there's a limited number of hepatotoxicity that they found, and individuals, they had no pre-existing hepatic issues, but it happened. A chance of depressive disorder that they found, risk of reduced drug concentration due to interaction. So like drug interaction can decrease the concentration of the Aperture, so that would be an issue. So you want to do your drug-drug interaction. Call your pharmacist. A plug for pharmacists will help you with that. Risk or reduce drug concentration, so adverse reaction. So the common adverse reaction when people got their shots was injection site reaction. So we also advise them to either do a cold or warm compress for about 15 minutes. And you also want to watch them in the clinic for about 15 minutes as well. And what else? And again, drug interactions. And when it came to populations such as people who are breastfeeding, so it's not indicated because you have to assess the risks versus benefits because we're still doing ongoing studies about it, and it's not recommended in pediatrics. Next slide, please. Let's talk about PEP. Does anybody know what PEP is? Post-exposure prophylaxis. Yes, this is super important, and I think that this gets underutilized, and access is an issue. So post-exposure prophylaxis is the plan B of HIV. Does everybody know what plan B is, right? So plan B is when I'm a pharmacist, so I used to see it all the time when I used to work in retail. It's Saturday morning, they had a good time, and things happen, the condom broke, and they run in, and they come get their plan B to prevent pregnancy, right? So when it comes to HIV, so let's say you got exposed to somebody got raped. Within 72 hours, you can take a treatment, which is actually an HIV regimen, and it includes Truvada and Descovy for 28 days, and it prevents someone from contracting HIV. But time is of the essence, right? 72 hours has to be within that timeline, otherwise it's too late to take the PEP. So something that's a big advocacy for me is that once a patient gets on PEP, even if it's a one-time situation, that patient on day 29, after that 28-day regimen, most likely in some cases should be on PrEP. It's definitely important, and it doesn't happen. Usually people are like on PEP like 6 times a year. I'm like, what is going on? Like they need to be on pre-exposure prophylaxis. So unfortunately, it's really, what happens is, I remember being a retail pharmacist working for one of the big box pharmacy, and a patient would bring me like a prescription for Truvada or Descovy, and I would just assume that they were positive. Like, even us as clinicians, we don't know enough about this. The only reason I know about this is because I do it every day, right? But like 4 or 5 years ago, when I was just a retail pharmacist, I would not know. And this patient doesn't have insurance, right? So there's access to get this at no cost. The drug companies have programs. You don't even have to be documented to get this covered. So the issue is that, you know, I feel like the providers in an emergency room, Dr. DeFreddy, maybe send this message, they need to put that time is of the essence, and this is for post-exposure, because yes, yes, exactly. Occupational post-exposure, yeah. That's why it's called an NPEP, right? Because it's non-occupational, correct. It's the same treatment. But the thing is that there's a lot of programs to get it at no cost. Like Gilead takes care of the Truvada, and the Vive takes care of the Descovy. But the thing is, say it again? Tivicay, sorry, Descovy. I'm thinking about PrEP. It's called Tivicay. Tivicay and Truvada. And Vive takes care of that. So they have programs to get it at no cost. Next slide. So everything goes back to getting tested, right? We just have to go out there and get tested and tell everybody to get tested. I mean, you get tested, you're negative, you're at risk, you educate on PrEP, you discuss with the doctor, and then you take your PrEP. But let's say you get tested and then you're positive, you get retained into care, and your viral load is suppressed. That's also prevention, right? So let's focus on the status neutral model, because that's the only way we're gonna ever tackle this problem, end the stigma, and get everybody in treatment. Next slide, please. So this is just a nice chart that I found on the CDC's website that talks about like how to pay for it. So there's a lot of programs besides like, let's say somebody has Medicare. There's a program called the Patient Assistance Foundation. It's like a foundation that has money. They give about, like $7,500? $7,500 a year to cover. And they actually also added where they help pay for the premiums and the deductibles. So there's a lot of programs out there. And something else I want to talk about is that, you know, we got to take care of those social determinants of health before we come and offer somebody PrEP, right? We can't just say that like, oh, you need PrEP. If they're hungry, they're not going to care about PrEP. If they don't have somewhere to sleep, they're not going to care about what you're talking about. So what we do in our clinic is that we came up with a collaboration with the Urban League, where we have somebody there that's helping the patients navigate to get insurance, like with ACA, or if, yeah, social worker, yeah, they have like an insurance navigator. So like, imagine, you can't just take care of, like, all we could take care of is the PrEP. If they tell me, oh, I need an HPV vaccine, I can't do anything about that. All I can do is, you know, get you to the navigator, get you your primary care, because what they're saying now in the new guideline is that PrEP is the gateway to healthcare, right? So this is a perfect opportunity to take care of everything else, because it's not just HIV prevention. It's, I need to give them a hepatitis shot if they don't have hepatitis, right? I need to give them a monthly physical. You know, that's super important. So this is just like a nice chart that I included that tells you all the ways to get PrEP paid for. And there's another program that's called Ready, Set, PrEP. It's actually funded by the government, and it's irregardless of your income. The minute you don't have insurance, you have access to PrEP at no cost. So it's just so many programs out there. And again, insurance is like the way to go. And now some people don't pay anything for affordable care. And it's pretty good, the plans that they have. Next slide, please. And these are just my references. And that's it. Do you guys have any questions? And thank you so much for helping me. Right. I mean, I think that like in the times of COVID, I think that like if someone should be offered an HIV test when they go get COVID tested. Why not? You know what I mean? Like it should be easy to access. And like our organization that I work for is called AIDS Healthcare Foundation. Like we have a mobile testing unit that drives around the community and we test people. We pull up everywhere. Right. Like they come from Ukraine and then it's like a spread and a community spread. We have one in Haiti too. Yeah. I love that answer. AHF in Ukraine. Yeah, AETC. I think AETC will send it to everybody in an email, right? Yeah. Yeah. Is it C? No. Okay. If you went to Fort Myers, you would have got a C. So, any questions, concerns? I have a question. How do we get my people in my Haitian community to get on our mobile to get tested?
Like today, we had a very good experience with the students. Out of, like, we was at the police department because we want to not educate the police, like make the police department aware of like the HIV testing. It's something that's very important in our community. So we need to enforce that in Miami. So the police comes, we have fun, we go, we have the coffee with the police, and after that, they come at the testing site. We took a picture, right, girls? And after that, they disappear.
They don't want nobody to know.
Nobody was there to take the test. But it was an experience for them because I know that it's not easy to have the Caribbean to get tested.
Yes.
Like especially when you woman and you are talking to a man about testing for HIV or giving them condoms, you need to be a second me to do that because it's not easy. They're gonna tell you all type of words, but you know, you chill with them and you make it, you know, because the importance is get them tested. It's a very big challenge. So my question for you, how, if we cannot get tested, how we can introduce to our a Caribbean, like which is they never have one woman. How can
Say that again.
Oh, I'm sorry, guys. I'm sorry. You know, when we talk in general. We don't talk about like I know you are one man. But we talk in general because we have a lot of men in the Haitian community. Like for example, they have multiple women, and sometimes they having sex unprotected. But when you tell them it is not safe to have unprotected, but if you have unprotected, at least save yourself from getting HIV.
Exactly.
By the way, like the PrEP, gonna only save you from getting HIV. But the
Yes.
other STDs you expose.
Condom is the only thing that prevents STDs.
But our Haitian men, or like let's say women, Haitian in general, they don't want to hear about it.
Right. Let's talk about the fact that they don't want to wear a condom either.
No, they don't want to wear it. So what are the mechanisms that we can use to educate them or to teach them to make them like this is important. This is your life. This is everything. How we can get to them.
So I think that our providers, like Dr. Dufresne, when he's prescribing that Cialis and that Truvada, and then that Cialis and that Viagra, needs to put a little Truvada and Descovy with it. That's where it starts, right? Because you know your patient's going to Haiti, come get that Cialis from you. You got to give him some Truvada to protect his wife, right? Do you do it? He's like, yeah. Right. Exactly. Wow. Right. You take care of those social determinants because there's gonna be no adherence if she's hungry. Right.
But the problem is giving patient incentive to do the test or to do whatever. It's not really, it's not legit to do it. The patient, like in our community, for example, they need to know that it's important to take care of myself.
Right.
I don't have no problem with you having multiple partners, but it's protecting each of the women or men that you are having, intimate relations with.
Exactly.
Because let's not like quote unquote say patient, but men or women in general. If you know that it's your life, you can do whatever you want with it. But protect the next one, the next one, the next one that you have it with. And the resources are here since we are live in Facebook and on the pages. So or everybody that listens to us, this is not a game. This is a very important subject that we need to think about. Because if you don't want to protect yourself, you're gonna kill 5 men or 5 women that having this
They
thing
don't
with
care.
you. So for me, it's hard to do because I deal with them every day. But I think they need to take responsibility and carry that to say no. This is time for us to taking care of ourselves and to take it because it's not gonna kill you. It's gonna save you from getting it.
Maybe we gotta make the first date the testing site.
By the way, but today we had the prostate man was come. I said one of the things to make the men come, it's got the prostate screening for them. None of the police show up. None.
You're not talking about him.
But none of them come up because they're, we was at the coffee, very good. Taking picture, very good. But when it's the testing, And they're scared of doing it.
And I think it's about how we word things too, right? So with the Haitian American Pharmacists Association, we were working with Empower You with Marjorie Lozama. So she's like, yeah, I want you to come and educate my patients on HIV and how to treat them. So my eyebrows went up. I'm like, they should just say prevention in general, not like HIV. So we signed up. Nobody signed up. We had to cancel it.
I forgot to miss you, Marie-Hélène. When she's do Mary, how you do when to do the testing? She has a certain words. How you do with the patient just to get them tested for
I
HIV?
can, we are search for bacteria.
You're in search for bacteria.
And then they come.
I'm gonna use that one. I like it.
There's a person today that tested, that went to COVID test, and I think she got it to get the.
HIV test. I'm gonna have to use that.
I have a question, Sandra. So
Sure.
How do you get, so today we did testing, and we have the nurses here and us, right? How do you really get to a place of inviting and like an enticing way? Like, how do you get the person to get us, in your experience, to get them to see the real benefit and like we already see the guidelines, we know that it can be beneficial, but how do you get that in the personal level, in your experience? Like, how do you make it make sense to them and like, look,
Are you talking about my community? Or
well, yeah.
okay. With our community, the first thing is the privacy. That's the first thing. If you want them to even listen to what you're talking about, it's the privacy part because we've been stigmatized. There's been times in our history where people wouldn't purchase a home from us because they thought we had HIV. You couldn't get a job, right? So that stigma still has a lot of impact in the community. So make it as private as possible, discreet, right? Because they're thinking is somebody I know gonna see me? My neighbor gonna see me getting on this mobile to get tested. So I'm still trying to figure that out. I want some ideas because when we pull up the mobile, they run. Our organization says AIDS Healthcare Foundation, so they're definitely not getting on our mobile. So we're trying to figure that out too. It's a challenge. Does anybody have any ideas?
October 7th after the training. We're gonna have her go at October 7th.
saturated throughout media. Mr. Bell, we are not related, but this is Sony Bell I'm from, and I am Mrs. Bell. But we can start off by educating through marketing practices. He has, his social media platform. I do as well. I work as an influencer as well, and I'm in the political scenes. But to get the information out there, disseminate the information out there through all social media platforms would be the way to go.
I agree.
Since this is a digital world that we live in now.
Yeah, maybe like one of our Haitian celebrities to actually get a test, right? Live on Facebook or something.
We can do that for you. Like every December 1st, each December 1st, I go to Compare Event or Giveaway to have 1 hour show to talk about HIV and AIDS live. So we have a lot of people calling after that, asking questions, and I think that they ask the good question, but having them coming to do the free test, they don't. And for me to do that show, you can go to my page and see MJD Wellness and Community Center. That show, I need to make the show very interesting, very talk about sex, talk about I even bring demonstration of the genital part just to make it fun for people to be able to stay. They have 20,000 people watching them when they put music, when they talk about other stuff. When the wellness comes, 10,000 people are already gone because they have their information. For you to keep the audience to the 10,000, you need to go to their level to make sure you have
Right.
that 10,000 people. But for me to do that, I learned for 3 years how to keep them, to watch me, to listen to what I'm saying every December 1st. I have show with Alcopa even. It's not easy. And with TOUCHEDOUCE too, I do that. When I do the show, I share it with different platforms.
So you know Jenny Gerville.
It's not easy. And I've been doing testing for the past 5 years. And my target is my community because it's a taboo subject. As a woman doing this, you have they give you different titles. That's not even, you're not that person. They give you all the name, but I love those names. What is important for me is get my test done. It's not the name that you give me. Some people could say, oh, if you give me a condom, what I'm going to do with it? I don't have no women. I say, I'm here, baby. Because I want you to tell me. To get you tested. Oh, when I have one wife. And most of the Haitian people that get HIV are people, excuse me, MJD staff. Most of the people that get infected are people inside of the church.
Oh, yes.
The highest rate.
Yes, because they believe in the wife or the husband. They're not doing nothing. They are Christian, but they don't know when you go out of the door what you are doing outside of the door when the door is closed.
Oh, yeah.
So that's when I told Violet, our MA, I said, I want to go to your church to do a presentation in your church and to talk about it. We've been 6 months. I didn't get.
You still waiting?
Yet. I'm still waiting.
I hear
it's
you.
not easy because the subject, when you woman, a single woman talking about sex, talking about HIV, they don't see, with the good eyes.
So I've done this conversation at a SDA church, and at first they were like, "Oh no, no one's having sex before marriage. It's not biblical." So I told them, like you said, you know what you're doing, but you don't know what your partner's doing. Then I got their attention. Now they were listening. Right? That changed the narrative. So it's about how you say it. But yeah, I know that was a challenge. SDA church on a Saturday after church. Of course, the adolescents, yeah. Right.
After that, I cried because I realized all of them they are sexually active. And when I was talking about that subject, the girls' mouth dropped like, huh? And I can look at them with my dark glasses. I'm looking at everyone around me. Oh my God, like it's just a but this is one thing we have to start with them as well.
Yes,
Go to the high school, go to the university, join them because
exactly.
they think, most of them they think that things is hard.
And if you think about it, like that's probably like the safest, most private place is at school, right? They're not gonna ask their parents to go take me to get tested. You know what I mean? Like we need to bring it to them at school. Maybe pull a table up at the cafeteria, right? That's what they're telling us at our house. That they would bring something like a table in the cafeteria, and then they would just come in. And if they want to get tested, they could get tested during lunchtime. Yeah.
Churches don't, it's the same thing when I used to talk about human trafficking, child sexual abuse, domestic violence. The first time I asked to talk about it, nobody wanna listen to me. Unfortunately, for the one day they gave me the pulpit, honey, I talk about it. My sermon was only about da. When I feel they never invited me, I say I don't care, but you heard me.
Yes. You sent your message. Message was sent.
Yeah, most of the time we see that inside of the church, but I call them hypocrites.
Right.
Because you sit down there, the husband, you know they are doing what they're not supposed to do. And they bring this, I call that, for me, this is a crime.
Exactly.
When your wife is not doing certain things, or your husband is home, you spend himself and you go in the street, get all of those girls, you don't know you. Because I tell you, if a man decide to go, a woman decide to go with you, believe me, you're not his husband. That person has someone else outside. You think you are the only person who's gonna lay down with? No. And you don't know how many people that person is laying down with. If you're doing your business home to your wife, for me, this is a crime.
It is.
This is a crime. And therefore, one of those in the churches may not pay attention to my sister. Because when I'm watching your presentation, you go straight to it. Ta. This is what to do. This is what to do. But most of the time, you have to go like this. Like we're talking about prevention first. And while you're talking about prevention, you need to open them. When they heard about prevention, they're going to open the door for you. But they think you're going to talk about HIV, this is what
Exactly. You have to say prevention. It's your presentation. Another thing is our providers. Just because a woman is married, you still give them an HIV test. Doctors, please, because I've seen that case happen so many times. Working in infectious disease, the patient never got tested. She's married. The Haitian doctor, Haitian woman, OBGYN catches the HIV. So this is a problem. Yes, her husband's the only person she knows, but the husband, that's not the only person he knows. So it's very important. The consent, right? Because you have to sign. That's true. That's advocacy, right? That's lobbying. That's laws.
When we, the doctor, when we prescribe like the panel for the PrEP panel, we don't do the consent. Like it's the HIV, it's all the the lab that
It's
we
true.
are sending out.
I did my physical the other day. They made me sign a consent too.
No, the change that we have right now, the youngest generation now is very open. They come to the clinic primarily to do the testing. Oh, okay. Like I think Tuesday we have a patient that came to do HIV, not STD testing. Said, oh, I was exposed. I want to know the status. I said, okay, no problem. We did the HIV, the rapid test for him, and he was negative. Thanks God. I said, okay, now you need to see the provider. So for the provider to send you for more tests to see if you don't have other STDs.
Right.
You know, so it's for me, it's very important that we do that.
Right.
Miss Jeannie,
But remember the rapid test, right? That could test HIV that's 90 days out, right? So if someone just got exposed, they might need something like a fourth generation or like a viral load, because the at-home testing kit, that's another thing too that can help with our stigma. The patients can call the health department. Every health department is sending free at-home tests. So you don't have to go to a place. You don't have to hop on the mobile. You can just call them up and they deliver it to your house. That also helps.
we have it too.
Yeah.
But the county doesn't have a lot of home tests.
Okay.
But we have some home tests. So we
Yeah, they went fast, right? They bought like $2 million and they're gone.
It's on a second, like
Yeah.
they're gone. So we have the home test, so we can give it to the patient.
That's
to do
nice.
the own test at home. And today, like it was a very good experience. They don't have a lot of people. I told them already. Today was able to do the testing and see how the community react to the type of the test. It's
Welcome to the Haitian community. The rapid it's sensitive in terms of timing. So like, let's say a patient comes back for a prep follow-up, there's no point in doing a rapid, right? Because they're testing every 3 months. So it's somebody who's never tested, who uses a rapid, who's never tested in their life, or it's been like 5 years, they've been scared, it would catch it 90 days.
we have a last question.
Yes.
So you're thinking, how are we going to get the Haitian community and how are we going to educate? I think, and I don't know if this is the right answer, but I think that someone mentioned social media, and I love social media, but I think the talk show,
Yes.
I'm thinking radio, I'm thinking Manuela, or you need to be on there and get the DJ to start asking questions.
Yes.
About prevention. And
It's
then
true.
you can say, we, have this community, and then the nurses here say,
It's true.
go ahead and bring that Google music. And they will come.
Yes.
So you start initiating and setting that desire for
Exactly.
and
No, it's true because the health departments are like, this is like, oh my God, how are we going to get to the disparity communities? I went to a conference and what they were doing, it was a group of women and they were doing like brunches, right? They were doing like the painting with the twist. We're talking about everything else. Then we slip in the conversation, right? So now that we're getting to know each other after a couple mimosas, let's talk about it, right? Let's talk about everything. We open, like, so in this conference, we actually talked about how black women, we took over everybody's problems, and then we take it in and then we don't take care of ourselves. So like, imagine having like a round table just talking about that. Then you can digress into the other topics. So I think it's just having a conversation, and because people always love to just hang out and have a nice brunch and just hang out. So I think that, that's a way. It's like super simple, but you don't have to always go right away into having the conversation about prevention. And another thing is providers need to ask those sexual health questions. I don't care if you're married. What kind of sex are you having? Are you having sex with men? There's a lot of stuff going on. I have a patient. I have a girlfriend. I want to protect my girlfriend. Her immune system is low, but I also have sex with men. So there's a lot of different stuff. You have to ask all the questions. And I know it's a challenge to our community because our doctors are not asking that question to those married men, because things are happening. So we got to talk about it. So that's it. That's all for today, guys. Thanks for listening to me.
Thank you so much. Let's say thank you so much again. Let's give a round of applause for the beautiful, doctor, for this amazing presentation. Today we have with us some guests. Those guests coming from Virginia. Earlier I didn't present them. We're gonna call a couple of people in the community. We're gonna give them something, because we don't know if we're going to see them again after this year. They're going to come, but they're not coming to this type of presentation. So we're going to give them something. They can go home with it. So they're going to show their community that was there in Miami, and this is what they come with. I'm calling the group of nursing to come here, please. Where's Miss Martia? I'm calling the chief, which represent the North Miami. Come with me, please. I'm calling our provider, Paz. Can you come, please, Dr. MJD staff? We're going to give each of those people a medallion. So to give to them, give the Dr. Paz, Sony, Nadia. Come and put the medallion for them for me. Yes, go. Give them some. So, on behalf of the city of North Miami, he will welcome No, give him so he can give it to them because he's the chief. No, give the doctor. Doctor will give it to them. Yes. We would like to thank you for being part of the community, to work so hard. And this is the beginning, and we're waiting for you since Miss Montia said she's waiting for you to go to UM. Because they are the guests. You know, all of you, we are from Miami. So, that's not a problem. We need everybody that's here for the first time, we're going to give them something because we don't know if we're going to meet them again. How many we have left? We calling, no, Paz is not a guest. Paz, we have to honor him, the cameragrapher right there. No, please, Paz, you're the owner of this agency, man, for the past 7 years. You know? Yes, him is here for the first time, yes. We are calling our speaker, she's here for the first time. For the first time. We are calling someone, he's a media, he's come from Haiti. We're not calling nobody else. Oh, we want you to come because as a guest, he was with us this morning, you, and he's with us again. Come here for the first time. So the time is up, we have to go. How many we have left? How many? Come here, first time. Our first timer, we may not see you too. Come here. We may not see you again. We may not see you again. But come here. How many we have left? 4? 2? Okay. We need you. Please come here. Yeah. Oh, okay. So, come here. Yes, you are first time. All our first timers. You the first time. No, he's not the first time. Where's the 2 more?
Thank you.
Yeah, you're welcome. Stay here. First timer. Leo was. Well, this is not for Leo, but we're gonna give Leo this because he's the one that introduced us to where we at right now. Leo, get up. Yes, I wanna give it to you. Yeah, first, you are the first timer. Come here. No, not everybody. Not everybody. Come here. The photographer, come here. You first time. That's it. You first time. Yeah, one more. Yes. But there is something special, not for the first. Every first timer has one. But this student, we want to give them something live to show them that we love you. We appreciate everything that you do today in the community. It was very hot, but you was able to work and make it happen. We are calling. I want the professor to come with me, please. Yes. So you can call all your students and give each of them a certificate of the time. They're going to complete 16 hours. Woo. The first 8 hours was today. And tomorrow they're going to the food bank and to the clinic to do clinical work. If the big boss right here allow them. This is our medical provider. Yes. So he's, yes. And tomorrow they're going to be able to work with Mr. Renee and Miss Liz. Because today they was working with the 3 of us, me, Marie-Hélène, and Violette. But doctor was not here. But doctor going to give authorization if you can go to his EHR system to see patient.
Did you want me to give them now?
Yes, ma'am.
Okay, Chloe Gibbs. Yes. Stephanie Corey. Olivia Barnsley.
Graduation, right?
Yes. Amanda Johnson. Victoria Alfred. Ashton Spence and Chrisana Green.
So, yes, no, that's that. They are students, so that's
That's show you that we appreciate your work. Nursing, it's a hard work. Doctor doesn't do, I'm sorry, Dr. DeFreno. Doctor doesn't do nothing. You guys the one that gonna do everything, and doctor gonna be very, rude with you. But it's a very challenge major. I want you to go every time that you look at this, remember the MJD, where I come from and where we are today. So this is for you to show you are a hero. You're going to a hero major. So make it happen. Don't do it for money. Do it for love, for passion, because serving, yes, doctor, serving people is not about money. It's about passion, because we was on the sun earlier. We didn't make no money, but I was happy. We come back again to have that beautiful educated woman educate us about HIV. That is amazing. Thank you so much for being part, and see you tomorrow.
Let me tell you something just really quickly. We have assigned each student to do a reflection every morning. And who did it? Chloe. This proverb here, this is what she read this morning.
Oh my God. Okay, let's have a group picture of everybody that was part of this group. But by the way, we have our health and wellness conference. I'm sorry, we have our health and wellness conference October 7th. But if you want to come, you are more than welcome to come back on October 7th. We're going to have a one day that from 8 to 9 health conference. Oh, there's one staff I didn't present you. This is my daughter, Rachel. She's been an MJD when she was finished high school. Now she's graduate. She has a master. And she's one of the youngest entrepreneur in North Miami. And we have Anne. She's not here. She's the youngest. Now she's in school for sonography. We have Naomi. No, Naomi is in school for sonography. We have Anne. She's in school for medicine. Because what we do in MJD, we embrace these young girls so they can become entrepreneur. They can be healthcare professional, not any professional. Healthcare professional. So that's what we do. And we are open home to receive you again in North Miami. Thank you so much.
Thank you, everybody. Oh, picture. While everybody's getting ready for the picture, I want to... No, I'll do it later.
am I speaking to the? Hello, hello. How are you? Invisible people. Did you sign in over there? Did you sign in and write your name and stuff? Awesome. I don't know if you did.